Fab. Welcome to the second Southwest ICU Network teaching. Gemma's on IT, no pressure. So hopefully we won't have any malfunctions. Do you want to share your screen, Gemma? Fab.
Can everyone see that okay?
Yeah.
Grand.
Yeah, so welcome. We thought we'd do a bit of a round of introductions first. And if you feel comfortable too, feel free to put your camera on when you introduce yourself, because I feel like I'll know people's faces, but don't know people's names. So yeah, when you're introducing yourself, just feel free to turn your camera on if you want to. So I know we've got Libby.
Yeah, hi. I'm covering Western ITU at the moment on rotation. So yeah, hi everyone.
Nice to meet you. And Glenn. Okay, well, oh, no camera, microphone. Okay, no worries. No worries. And who else have we got? Deborah. No voices, Polly. Okay, no worries. Hi, Debbie. And Deborah Simpson. So two Deborahs. Is that two Deborahs? Amy.
Amy and Josie haven't got video or microphone, so they're from Barnstable.
Oh, right, okay. Violet.
Hi, I'm Violet, OT at OUH in Oxford, just in case.
And Sarah's just joined us.
Hi, yeah, sorry I'm late. Sarah Churchill, Critical Care OT in Great Western in Swindon. I'm assuming that's what I was telling you.
Yeah, just doing introductions. And Manson.
Hello. You can just call me Winnie. I'm the OT in LUH ICU at the moment. I'm rotational post.
Nice to meet you, Winnie. Yeah, thank you for that. It's just helpful to know who we're speaking to. So yeah, welcome. So our session aims we'll start with. Next slide, Gemma.
Doing my best. There we go. Clicking works.
So some of the session aims we'll have today is understanding ICU, delirium in ICU, how we can identify that delirium and try and analyse any factors that contribute to that delirium. We'll try and increase our understanding of the role of OT in ICU delirium management and how we can structure our interventions to aid the delirium management of those patients. If we've got time at the end, we've got a case study that we can go through, and as always, please feel free to chip in with comments or suggestions or anything like that throughout. We're really, really happy for people just to jump in wherever.
Great. So our first job is going to be a bit of a Mentimeter. So you can scan this QR code with your phone, or I will change my screen in a second. So you've got the other login option. And essentially, how do you define delirium generally within the context of ICU? Essentially trying to get an understanding of what your understanding of delirium is, and then build from there. Stop sharing. I'm just going to share. Sorry, oh no, it should still. Does that change? Is that right? Grand. Hi, Kate, welcome. We're just doing a bit of a Mentimeter about kind of what your understanding of delirium is, how do you normally define it, that sort of thing.
Thank you.
No problem. We'll just give it a few more minutes, give everybody a chance. We've got 12 of 13 responses, so wait for our 13th and then we'll move on.
And just to clarify also, I wrote think they're going mad, or think they're mad, because a lot of our patients, when they don't understand what delirium is, think that they are in some kind of state of madness. So that's something that we quite often hear back from our patients when they're out of that acute delirious state. But the word count limited me from saying that. So just to clarify.
Okay, great, some really good answers there, and I think you probably very much kind of captured exactly kind of essentially what how we formally define delirium, which Shah will cover a little bit more in a second, but it seems that we've probably got very good understanding generally in the room of what delirium is, so that's a great place to start, guys. I'll switch back to our normal presentation. There we go.
So there's just a couple of formal definitions there of delirium, one from the NICE guidelines and one from the Intensive Care Society. Again, we're a room of OTs, I'm not going to explain, we're not going to explain kind of what that is to you, but there's a couple of really nice definitions there, which is just really, really helpful in your education with patients and their families.
So thinking about prevalence and outcomes in ICU, essentially what we know is it's a huge problem for our bed bases. NICE estimates kind of that anywhere between 70 and 87% of patients present with delirium at some point in their admission in the intensive care unit. There are lots of papers and studies out there that kind of attempt to estimate this, and it's really variable depending on the tool they use, the point at which they capture these patients, and actually what questions we're asking, because sometimes we can use objective measures of delirium. Somebody doesn't score, but they can still be subjectively reporting hallucinations, confusion, a change in their mental status from their normal, so it's important to get that patient narrative as well. Delirium has kind of significant impacts for our service users, as you're probably all very well aware. It can increase their length of stay in ICU and hospital. Kind of this is a circular process. We know that people being acutely unwell drives delirium, which then impacts their ability to engage in treatment and care planning, etc. So we get caught in this really vicious cycle. It can lead to prolonged mechanical ventilation if their neurology is impacting their ability to wean potentially, or their neurological assessment at the point that we're thinking about extubation. And unfortunately, delirium has got higher mortality rates both during hospital admission and after discharge into the community. For those patients that do survive that have had delirium, we know there are increased incidents of post-intensive care syndrome out of hospital, that they have kind of worsening frailty compared to their baseline function, and that they report poorer quality of life outcomes longer term. So it's a really significant problem, and something if we can, the earlier we can address and deal with, the better for these service users overall.
Fab. So how do we identify delirium in our patients? Sometimes, obviously, it's very clear that someone is delirious from their presentation. Looking at them from an end of a bed, you can see that they're in a kind of condition of delirium. In terms of formally assessing delirium, the CAM ICU, or the research says that the CAM ICU should be completed twice daily, but if not more, and it should be completed by the MDT. So your nursing staff, your medical staff, your physio colleagues should all be completing CAM ICU when they're seeing their patients. It's not just an OT assessment. Is everyone familiar with this assessment? Does everyone use it? Winnie, do you use it in Bath?
Yes, I do use it in Bath quite often. Every time, like if someone like even the doctor use it, but they sometimes I realize they don't do it like just following their whole things. They just give some of the bits and say the patient is delirious. But
Yeah,
sometimes you have to do more thoroughly, but we do use it like quite a lot of time.
perfect. Do your nursing staff use it as well?
Yes, it depends because not all the nursing staff know how to use it. I think it's not well educated across like the whole unit, but most of the people know at least the CAM ICU exists.
Yeah, we find exactly the same thing in Bristol. Generally, our nursing staff are very pro therapies, which is great. But I guess by us doing it, it's just providing that education, isn't it, and kind of leading by example in terms of the way that we assess delirium. So yes, hopefully everyone's kind of familiar with that tool. It mentions about RAS level. So
Oh, Shah, you're mute.
sorry. Can you hear me now? Perfect. So we spoke about this in our last session, our risk assessment session. So thinking about patients and how meaningful your rehab is going to be with patients who have got a RAS of +3, -3. But potentially your patients that are +2, -2, they're the ones that we can make a really good impact with. Even if someone is quite agitated in a bed, if they're kind of wanting to get out, then maybe thinking about ways that we can facilitate them moving around. So yeah, the RAS is part of the CAM ICU assessment as well, and something hopefully that we kind of use on a daily basis as well in terms of our risk assessment.
So here we've just got a bit of a mind map that kind of demonstrates all of the different factors that can kind of contribute to delirium, make it worse, kind of the risk factors that we might be able to pick up immediately in somebody's medical notes. On the right hand side, you've got the non-modifiable factors, and some of these will be really familiar to all of you. The things that we see frequently on the ward with delirium, like advanced age, kind of pre-existing cognitive deficits and frailty. But there are some things more specific to ICU patients that maybe we wouldn't normally see on the ward, but in the intensive care unit we would still work with. So somebody's in an active septic process, somebody with severe kind of respiratory failure and severe anemia, we may well still pick up, and we'll talk more about that in the next slides. Obviously we adapt what we do to suit their kind of clinical stability, but this is where maybe we sit slightly differently to our ward-based colleagues. And then Shah's going to talk to you a little bit about some of the modifiable bits.
So again, hopefully an area that we can make quite a bit of difference to in terms of our assessments and our kind of contribution to the MDT and how we manage the delirium drivers. Drugs that we know are a massive one. So like Gemma said, a lot of drugs that are used kind of within ICU aren't used on wards purely because of patient acuity. So analgesia, so things like morphine and fentanyl, things that we are very strong painkillers, they can also contribute to levels of arousalness and attention. And again, thinking about your kind of input with those patients who are on those kind of really strong medications. Sedation, so anything from things like haloperidol, midazolam, lorazepam, things that are used to keep people safe in a really acute state of delirium, or people that are very anxious because of delirium. Also, impacting the purposefulness of therapy. So if someone has had haloperidol overnight, they had multiple doses of haloperidol, and you're thinking, right, I want to go and get my patient out of bed, I want to kind of introduce a bit of a sleep-wake cycle and a bit of an activity routine, thinking about the impact of those medications that we'll have on that patient's presentation. And it's really hard to get that balance. Alongside those kinds of sedatives, you've also got your patients who are on mechanical ventilation, will usually be sedated. So things like propofol. It's commonly used, but it's not ideal in the long term, purely because of the neurological impact of that. Remifentanil is one that's really good for assessing neurology. It has a short half-life, so it's something that can be weaned quite quickly to assess someone's neurology when you're aiming to kind of take them off that mechanical ventilation. Things like, I can never pronounce this word properly, but dexmedetomidine, yeah, it's a neurosedative that's similar to propofol, but hopefully has, or has been shown to have reduced longer-term side effects. If you've got your patients that have been on mechanical ventilation for, a week plus, and they've been taken off ventilation, thinking about the impact of that sedation long term. So thinking about weaning that sedation and how the withdrawal can impact someone. Quite often patients that have been on sedation for a significant period of time will be agitated, confused, disorientated. So yeah, something to think about in terms of when you're seeing those patients day one post extubation. The environment is a really huge one, which again, I think again as a tease, we have kind of a massive influence over to a certain extent, as much as we possibly can in an ICU environment. So thinking about the sleep-wake cycle for that patient, often we know that these patients don't have any access to natural daylight. They don't have any differentiating between night and day quite a lot of the time, especially if they're sedated, or kind of weaning off sedation. They probably never enter restorative sleep state, so they haven't got that pattern that we usually have. Sensory and occupational deprivation. So if we think about all of those home comforts, the things that we do day to day that provide us with those little pieces of joy and little comforts, things that establish a routine for us in terms of all of those different senses, that is taken away from someone. They're in the same room, in the same bed for probably 20 hours of that day, if not more, if they're not in a kind of rehab phase yet. So thinking about that as well. In terms of people will often won't be wearing glasses or have hearing aids in those really acute stages as well. On the other hand, you've also got the sensory overload. So you've got kind of constant lighting, constant conversations that are happening around you, kind of wires, tubes, everything that's kind of covered in your body that would be, incredibly unpleasant. This could be especially distressing for people who aren't neurotypical. If people who are more sensitive to sensory changes anyway. So thinking about that with that cohort of patients. Immobility. So we know there's a huge link between reduced sensory motor input and cognitive decline. Like I said, patients are in bed for 20 hours a day. If they can't be moved for various reasons, we're thinking about how can we possibly move them. There's also the use of restraints as well, and every trust is slightly different in how they restrain patients. In the BRI, we typically use like physical restraints onto the bed for patients that are pulling at important wires, tubes, that kind of thing, as opposed to like a pharmaceutical management of that delirium. Like I said, it's different in every trust, I think. And pain is obviously a huge one. It increases the stress response, it increases the risk of PTSD for someone who's leaving ICU, and obviously the medications that they use for pain relief have that big impact as well, like we spoke about earlier. And prolonged mechanical ventilation. So we know that increased sedation will come with altered neurotransmitter balance, which means that patients will have reduced sleep-wake cycle, reduced orientation, and ideally we should be keeping patients off deep sedation for as long as we possibly can and starting to think about weaning that sedation as soon as it is safe to do so. Obviously that is guided by the medical team.
Great. So kind of skipping back to some of the non-modifiable bits from our perspective, at least, I just wanted to briefly reflect on last session and kind of the biochemistry bits that we looked at as part of risk assessment. I've put some lab results up here, kind of which aspects are you guys looking at? Please shout out, use the chat, etc. When you're thinking about your patient's kind of level of delirium, what you're going to be able to do to influence them, which bits are standing out to you on this slide? OCRP, yeah, that was one of the ones I got highlighted. Yeah, and then you've seen kind of your white blood cells have responded to that raised CRP. Yeah, urea is another one. Okay. So yeah, we've said raised CRP, white blood cells, urea, and the other one I probably pay attention to is your creatinine as well. So CRP, as you probably all know, C-reactive protein, is a marker of infection that can flood kind of our blood-brain barrier and cause neuroinflammation. So it drives delirium quite significantly. We will often see this raised in our post-op cohort as septic patients or patients that have kind of a severe single infection as well. Creatinine, this is a waste product of muscle metabolism that's usually filtered out by the kidneys. And similarly, urea is a byproduct of ammonia that's broken down by the liver, and this is excreted through our urine by the kidneys. Both of these proteins are neurotoxic, and when they accumulate in the blood, oh, sorry, my computer's shouting at me. When they accumulate in the blood, we can essentially see that it's impacting and driving delirium. The question we kind of have to ask ourselves, is this something that we can influence or change at this stage? Is our therapies and kind of getting somebody moving more important than preserving the lines, their attachments, their ability to be filtered? And those are questions to pose to your medical team. We know that patients often have multi-morbidity when they come into ICU, and that can include kind of renal failure. So this might be somebody's baseline creatinine and it's not influencing their delirium at all. So these are all questions that are worth asking. Another thing that we often look at here at the BRI is arterial blood gases. Is this familiar to everybody? Do people look at this in their practice? Thumbs up, thumbs down. Something people know of but don't feel very comfortable with. Violet, in Oxford, are you guys in the OT team looking at ABGs, or are you leaving that to your physio colleagues?
Mostly to the physios, but we do have a look and have a chat through.
Yeah, fine. What kind of things are you looking at on your ABGs?
So looking at pH,
Yeah,
carbon dioxide. We do also look at lactate levels as well.
yeah. Cool.
The electrolytes. Yeah.
So
and sodium levels, isn't it? Yeah, that. Yeah.
So we can see those things in kind of our standard bloods as well. When we're looking at ABGs here, we're thinking mostly about our pH. Oh, is it going to work for me? Our pH, our PCO2, and our bicarb, our HCO3. ABGs essentially give us a sense of how acidic or alkalotic a patient's blood is, and that's signified by our pH. Usually that's between 7.35 and 7.45, the lower side indicating acidosis and the higher side indicating kind of an alkalosis. And an out of range pH can be driven by one of two things, and that's our PCO2 or our bicarb. So PCO2 is a marker of respiratory function, and it tells us how much carbon dioxide is in somebody's blood. It normally ranges from 4.5 to 3.5. A high CO2 or hypercapnia, as you'll hear it being called, means your patient is retaining carbon dioxide and is likely not breathing enough or taking deep enough breaths. In opposition, hypocapnia, which is indicated by not enough CO2 in the blood, is a result of breathing too quickly or too excessively. Both can result in confusion, reduced GCS, and if not effectively treated, death. So that's worth considering if it's super deranged, because we probably need to get on top of that before we do anything. Metabolically driven pH changes are indicated by HCO3 or our bicarbonate, and it's regulated by the kidneys. It normally ranges from 22 to 26. Lower scores is common in kind of diabetic ketoacidosis and diarrhea, whereas high scores are secondary to excessive vomiting, diuretic use, and low potassium. In both incidences, we see fatigue and confusion, and of course, if not treated, mortality. Blood gases are really complex, and there's a lot of interaction between the PCO2 and the bicarb. They can compensate for one another, and we're not gonna go through all of that today, because it's kind of a session almost in itself. But it's worth learning. It's worth getting to know, because it adds meat to our risk assessment. It can explain either why our treatment is or is not being effective from a non-pharmacological perspective, because this isn't something that without medical intervention we can influence or change, and again tells us the suitability of this patient to engage in rehab and mobility. So it's worth learning. There's some really good resources out there for med students. It takes a 2-second Google and it explains it really nicely, so it's definitely worth having a look. And I've often found our medical colleagues are really happy to chat through some of these concepts just to help MDT learning. So it's worth asking that question. All right.
So you've got deranged bloods, deranged ABGs, your patients in a state of delirium, and this is what they might see. I've stolen this from James, but slightly modified it. So just thinking about ways that we can kind of help to ease that anxiety, and education often is quite a big one for those patients that are able to engage with that. We have a lot of times that patients will kind of think that their nurse that's looking after them is kind of out to get them, is trying to kill them, those kinds of things, or the doctor that is looking after them. And it's the way that we can kind of manage that. If you can't manage that through education and reassurance, then thinking, actually, if that's a really fixed thought that someone's having, then could we possibly kind of change that nurse, or suggest that they swap nurses, just to ease that anxiety in the moment. But I appreciate that's not always possible. But yeah, just a really nice visual there for what your patient might actually be experiencing.
Lovely. And then I just briefly wanted to touch on kind of the medical and pharmacological management of delirium before we jump into what we do. Obviously, we can't influence this in terms of actively prescribing or changing plans related to people's medication. But I do think one of our superpowers in occupational therapy is that we're pretty good at having an overview of our patients and everything that's going on for them. And often we can highlight these things to our medics, who can sometimes be quite system siloed, if maybe that's fair to say, and just need that prompt that maybe there's something they could adapt or alter to help manage people's delirium. So what's really important in terms of people's sedation or their benzodiazepine use is that we've got a good weaning protocol in place if they've been sedated or been using benzodiazepines for 7 days or more. Otherwise, we push them into a state of withdrawal, and we're working with somebody who's going to look like they're withdrawing from alcohol or drugs, and we all know that that's really challenging. So we need a weaning plan in place. Have we optimized somebody's analgesia? I have frequently come across post-operative patients who have had lovely kind of alfentanil, remifentanil running while they've been sedated, and then they've been woken up and they've been given QDS paracetamol and nothing else, which doesn't quite cut the mustard if you've had your sternum opened. So it's worth having a look at those things and making sure that we've got the right pain reporting scales in place. Can our patients actually accurately tell us that they are in pain? Are they too drowsy? Are they too hyperactive and just essentially not aware of their own internal body state? So making sure that we're using those right tools, and our nursing colleagues should be documenting that for us. Another thing that's really important for our patients that are using opiates, which I would say is the majority on ICU, is that we've got a good bowel management plan in place. Have we got laxatives prescribed to prevent constipation? Because we know that that is a problem when we have high opiate requirement. Have we explored their baseline mental health history? We know that essentially we know that we aren't. The NC pod report told us that we aren't looking at people's psychiatric history before they come into the intensive care unit. So we need to be looking at that as part of our social histories and making sure that people have got their baseline psychiatric medications integrated into their care plan before they're woken up from sedation. So that's really helpful. And we also need to try avoid using antipsychotic agents where possible for patients that don't need them. I think we'll quite frequently see quetiapine just prescribed as an in case to manage delirium. Is there another thing that we can use? Can we try using is there another strategy that we can trial? And then baseline substance misuse problems. Have we identified this and have we accurately managed it? Are we, how frequently do you walk into a patient who's just been woken up from sedation, who's potentially in nicotine withdrawal and doesn't have a nicotine patch? And these are really simple, quick fixes that we can identify if we're gathering a good social history, but we're also making sure we're being holistic in our practice and looking at all aspects of the medical notes. Great.
So we've just included a couple of tools that helps identify delirium risk factors. Pinch Me is one that I think you tend to see more on wards, but can still be used, in a sense in ICU as well. It's more of a tool to help find the cause of delirium and has more of a diagnostic kind of approach to it. But the one I wanted to talk about more so was the PADIS structure, which is on the next slide, Gemma. Fab. So yeah, PADIS might be something that everyone's very familiar with. Could you raise your hand if you use this day to day and document it and kind of use it to form your clinical reasoning? Fab. So a few of us are. How do you find it, Winnie?
I think it's quite useful, like to see, but sometimes you don't know what like to look for. But this one is quite structural. You can ask like in more like general way to see how's the patient at the moment.
Yeah.
From a more OT perspective, and all the things like you can see. For example, if you know someone is in pain, then you can see, oh, what could we do? Shall we let the nurse know? Shall we let the doctors know where's the pain? And to see how's their agitation, like is it settled or they got some issue, they worry, so that caused them a bit anxious. This kind of things you can base on that, like you can kind of find an intervention for them. So I think it's quite helpful. It's more like tackling what the issue.
Yeah, I completely agree. And I think, it sounds like you use it quite similarly to us in that it just helps to frame those kind of thought processes and helps to kind of give you ideas about ways that you can manage that delirium and how you can how your OT skill can contribute to the MDT management of it as well. Like Gemma said, I think we're quite good at having a really nice overview and having probably a little bit more time to look through notes and look through kind of patterns of behavior and things like that to be able to make those suggestions and bring those to like MDT meetings and things like that. So yeah, we try and use PADIS as a delirium management structure and have it documented in our notes throughout the entire patient interaction. And yeah, it's quite simple just to have in your notes and update on a kind of day-to-day basis and just kind of formulate your clinical reasoning for your planning for your patients. So PADIS, for anyone that's not super familiar with it, stands for pain, agitation, delirium, immobility, and sleep. So thinking about your pain scales, like Gemma said, if you've got a patient that can't self-report pain, then how is that pain being scored and how are we managing that pain? Agitation, so thinking about your Richmond agitation and sedation scale. Are they on any sedation? What level of sedation are they on? And is that sedation being weaned? Is there a plan in place to wean that slowly and gradually? Delirium, are we scoring their delirium regularly? What's the delirium delirium bundle delivery? So how is that being managed? What is the kind of care plan in place for that? And thinking about your bloods, thinking about your ABGs, thinking about those kind of driving kind of causes for that delirium, as well as any kind of environmental factors as well. Immobility, so what's their rehab plan? Have we got a structured plan that is person-centered and aims to kind of get them up and get them moving, even if that is sitting on the edge of a bed and being in an upright position or being hoisted to a chair? Are we creating a nice routine for that person to be up and be moving? Tabletop activities as well. So when we're thinking about immobility, also thinking about kind of activity and things that we can promote in terms of our activity kind of plan for a patient, what patients can do with their families, what patients can do with their families, what patients can do with the nursing staff that are looking after them. And sleep, obviously a huge one as well. So what's the bundle that's in place for that sleep hygiene? Have they, as a patient, on any kind of medication to support with that sleep? Quite often you'll see patients that are on melatonin for a short period of time to help with kind of promoting a sleep-wake cycle, but quite often our patients are taking things like Zopiclone as well to support with that. And how is that documented? Has it been accurately documented overnight? Are you getting a really good picture of what that sleep-wake cycle might look like for that patient? And how are we promoting good sleep hygiene for those patients? And even things as simple as earplugs and eye masks, making sure that our patients are offered those things to help promote sleep. So this is an example of what notes might look like, and kind of those thought processes might look like. This is just a typical patient, how we document them over in the BRI. For when we're seeing those patients, you will have to ignore the urea 71 because I don't think this person's urea was 71. I wrote this note, and I think that was a mistake there. But you can see how it's structured, and in terms of pain, someone's got a lidocaine patch in place. They're on PRN morphine. Are they agitated? So they're mobilizing. When they last used haloperidol, so kind of what that overall picture is looking like. Their delirium and their environment, and sleep as well, and immobility. Yeah.
Great, so another little Mentimeter for you. What are you doing in your units to manage delirium? What are your strategies? What are your kind of OT specific interventions? I'm just going to flick onto the Mentimeter thing so we can. So there you go, QR code and the login if you need it as well. We'll give you a few minutes. Got 18 people to respond this time. Right, we've been doing that for a little bit now, so should we? But yeah, really, really good. I think it looks like orientation and kind of access to natural light and trips outdoors are kind of our winning answers, and really good. It's really encouraging to see lots of stuff around daily planning and routine building in there as well, because these are the things that we know are helpful. Cool.
In terms of orientation, does anyone use like any kind of orientation aids in their ICU? anything other than just like clocks and things like that.
We use whiteboards and we write the date on there, what the weather is like, yeah, and who their nurse is, where they are.
Yeah. We also do that in the BRI as well. Try and have an orientation board in every patient's bed space, somewhere that's just in a kind of in visual field for someone, with same kind of information on there, where they are, why they're there, the date, whether they need glasses or hearing aids on there as well. Do you have like anything on the back of those boards, or any kind of other factors to it?
We tend to just take some photos around it as well.
Sometimes the like and dislike, so everyone
likes and dislikes.
Again, quite similar with us. We try and utilize the back of the board as much as we possibly can. We write patient goals on there, which kind of when we think about it, we think, should actually that be on the front of the board for people that are able to engage? Patients, should be able to see their own goals and have that as a really kind of self-motivating thing, and be able to see kind of what they've been able to achieve. So that's something to consider for us. We also have our speech and language therapy colleagues will write on there as well, about kind of swallow and communication and things. There'll also be a weaning plan on there as well. So patients that are have got tracheostomies, kind of what their weaning plan is. So the nurse that walks into that bed space that day has that in a really kind of visual place for that person. And what else is on those boards? Am I missing anything?
So it's the about me section, so likes and dislikes. So that's a really good tool, not only for the patient, but also for MDT communication. How can our nursing and our medical colleagues engage patients and things to support their delirium management, or to support them if they're not in a great place psychiatrically? So it's a simple solution, but we do actually see it being used by the whole MDT, which is great. Okay.
And I think most of the things in this list we covered when we were through the Mentimeter. But I think just in addition, meal support, so helping patients who are able to eat meals, kind of how they're able to eat and whether they're able to eat independently. And kind of building up a bit of routine in that sense as well. And also toileting, when we speak about kind of functional goal setting in an ICU environment, a lot of patients will say, I just want to be able to walk to the toilet. I don't want to be using a bedpan. I don't want to be using a commode. I'm fed up of nurses having to kind of meet personal hygiene needs. I would love to be able to do that for themselves. And in my experience, that can be quite a big turnaround for patients, is when they meet their own personal hygiene needs. So how we can integrate that as well, and whether that's part of therapy is thinking about ways that we can improve someone's independence with that and give them a bit more control over it.
And I think the other benefit of a good toileting routine is we reduce the risk of constipation, because people are using a toilet, something that they're familiar with and more comfortable with, so they're actually moving the bowels. But also, if we can consistently get somebody mobilising to and from the bathroom, they're not so concerned about urine outputs anymore, then actually we might be able to get them twocked, and that reduces the risk of infection, etc., all of which can kind of contribute and worsen delirium. So there's some real benefits to what we do as OTs and focusing on toileting early doors. Okay, so we're going to move on to a bit of a case study now. This is a 69-year-old chap who's come into our ICU with a lower GI bleed, pulmonary edema, and had an in-hospital cardiac arrest while he was in resus. He's got quite a significant past medical history that includes end-stage renal failure, hypertension, type 2 diabetes, and peripheral vascular disease. And as you can see from the image, he's got quite a high BMI as well. From a social history perspective, he was independently mobile around his home and able to complete his own personal care activities, but he did rely on his wife for the majority of his domestic activities of daily life. He used to enjoy playing skittles and golf, but now largely spends his days watching Bristol City football games on the TV and sitting in his garden. Based off of that alone, what are our red flags? What are our delirium red flags? Why might we take more of an interest in this chap's notes from an OT perspective compared to somebody else? can use a chat, can speak, whatever feels more comfortable. Yeah, so he's already got not great kidneys at baseline, so that's going to potentially have an impact from a biochemistry perspective.
I'd be thinking about the in-hospital cardiac arrest and thinking what well, we can assume that it was good quality of CPR, but thinking about what's the potential impact on cognition and neurology based on that.
Yeah, potential hypoxic brain injury, great. What about his kind of his social history? What's that? What have we maybe been able to indicate from gathering that? Yes, might need more support with functional rehab. He's higher up on the frailty scale, isn't he? Because he's not doing so much for himself anymore. He's needing help from his wife, and we need to know why that is. Is that a physical thing? Is that a cognitive thing? Is there a new kind of an emerging cognitive deficit at a baseline that we're not aware of? Anything else? Yeah, high risk of ICU acquired weakness and therefore immobility and therefore more delirium. Yeah. He's also got quite an extensive past medical history, so we can assume he's entering the ICU where we are gluttons for polypharmacy with some baseline polypharmacy. So we know this chap's kind of potentially in trouble from a delirium point of view. Oh, here we go. So next slide. This is day 31 of this chap's admission, and these are his blood results. Up until today, he has been mechanically ventilated and sedated. He was not successful when we tried to wean his pressures on the ventilator, and so he earned himself a tracheostomy. And as a result of kind of his prolonged ventilation, we had multiple kind of ventilator-acquired pneumonias. We've not managed to do any cuff down time with his tracheostomy yet, because we've only just woken him up. Looking at these bloods, thinking about your biochemistry stuff, your ATE risk assessment, what are your immediate concerns, worries, red flags? What are you thinking we might do with this chap? What are the things here that are going to be contributing to delirium? Yeah. Super high, yeah, very high creatinine. Yeah, so kind of hit the nail on the head really with that. His CRP is raised. It's not, you know, crackingly so. You potentially would see patients with a CRP this high. They might not do so much for you. They will probably be delirious, but this is astronomical, right? And this was his therapy note from the day. He was agitated, delirious, pulling at his lines, going for the trachea, kind of eyes open but flailing all of his limbs. We were not achieving anything with this chap today, and the medics were very keen that he had a day on the filter, so we left him to it. Basically, we did still go in, touch base, make sure that he was presenting as we might expect him to based off these blood results, and give his wife an opportunity to chat, because obviously it was incredibly distressing for her, and do that early family education. So still a valuable opportunity for some holistic practice, but we couldn't do so much for this chap. So we're going to move on. And we're slightly further down the line. We're now day 43. He's done well with his weaning, and we've been able to do 12 hours on his trachea mask with the one-way valve in place, and we're steadily moving towards decannulation. He remains CAM ICU positive, and we're completing regular PADIS screens as part of his assessment to facilitate his treatment planning, and this is his blood results from today. So things are looking much better for him, thank goodness. What sort of changes are you seeing in his blood results? It's probably fairly obvious that might contribute to his presentation. Based off of the PADIS screening, is there anything, what treatments, what interventions, what strategies might you start thinking about? What do we need to consider?
Just say there's a significant difference in reduction in the blood results.
Yep.
And I think at this point, maybe we'll just start some sort of stimulation, really.
Yeah.
Either through just to see looking at the RAS and see how he's aroused.
Yeah.
Maybe start using what family have brought in terms of orientation or voice. Yeah.
Yeah, great. So we can see that we've started to get this chap moving. We've got a non-hoist based transfer method. So he's actively participating in his position changes between therapies inputs, which is great. He's in a good, so initially this chap was in one of the bed spaces on our ICU that is essentially a cave, but we'd moved him to a room with natural light, which was really helpful in terms of his circadian rhythms. We know that his bowels are opening regularly. We've popped in some orientation kind of aids. Probably the thing that we need to really focus on now is seating and the management of that broken skin, because obviously that puts him at greater risk of infection and pain, and therefore not sitting out, so spending more time in bed, and optimizing his sleep cycle. And this is an opportunity to chat to family and think about what is his normal sleep routine. When would he go to bed? When would he wake up? What sort of environment does he sleep in? How much light does he have? How much noise does he like? Is there any strategies that help him sleep? I'm going to use my favorite example, and my partner hates this, but he listens to Harry Potter every night to go to bed it has to be on for an hour. If he was in ICU and not sleeping and that wasn't on, that would be the number one kind of strategy that I would say to his nurses that would be helpful. So those are some of the things to start to consider. Obviously, we've still got problems with his kidneys and his infection status. So until these things settle down, we're not, his delirium is probably going to continue to be a problem, but there's lots of strategies that we've put in place that means this chap is actually now has been in a position that he can actually engage in therapies and make some forward progress with his weaning and with his mobility. Great, so that was just kind of a quick example of the sorts of things that you might be able to do, but it doesn't obviously come without problems. And so we thought what might be helpful to kind of bring the session to an end is to think about what are the barriers that you're coming up against, what are the problems that we're all facing when we're working with these patients, and essentially just have a forum to problem solve a bit together before you disappear to put some of this into practice and then come back for the reflection session.
think we're seeing some themes, aren't we? The environment is a huge one, that lack of daylight, moving around. I know that in the BRI they like to move people overnight, which we love. Yeah, and the understanding of the MDT in the family as well, which is a kind of a constant education process to manage.
And lots of sensory stuff coming up as well, kind of limited abilities to engage in kind of positive sensory stimulation, all the things that they enjoy, but also lots of noxious sensory input in kind of internally, whether that's pain, temperature, etc. But then we've also got all the external beeps, lines, attachments, kind of tactile overstimulation from being touched and handled all the time. So there, yeah, it's a big barrier, isn't it, to what we do? But it is within our gift to do some education, to put in sensory care plans for these individuals. That sits within our scope of practice. And we can do a bit of digging in people's social history to find out what their normal kind of sensory preferences are. We can unpick that using our activity analysis. What are they engaging in? Are they doing lots of moving? Are they seeking vestibular and proprioceptive input at baseline, or are they a more sedentary individual that enjoys music and visual stimulation? So there's work that we can do to support these service users. In terms of adapting the environment, does anyone have access to Lumi lights? Is that something you guys are using? Any hands up for a Lumi light, or are we very lucky to have just 4 of them, but some at least? Yeah, so we've just, I think, finished writing our SOP for Lumi lights. I'm sure that's something that we'd be happy to share around if people need a SOP to base theirs off of. But yeah, they're a great resource because light access is a huge problem, isn't it?
This might be a good point. I know we're kind of come to the end. If anyone's got any questions or any comments that they want to put out to the group, feel free. We'll meet for, I know I can see Violet's typing, and Sophie, but we will meet for the reflection session on the 16th of June. Sorry.
I think I will just ask out loud. It was just when we're talking about orientation and about me, it was just, do you have a way of auditing that in your ICU that is being done by the MDT?
So we've done some within the therapies team. We've been doing diary and orientation board audits, kind of on an annual basis to see, are they in the bed space and are they actually being used and updated daily? And then kind of secondary to that audit, doing some questionnaires with the nurses as to if it's not happening, why is it not happening? Is there a kind of lack of knowing what to write in the diary, knowing what to write on the whiteboards? Is it a confidence problem? Is it a time and resource problem? Kind of trying to unpick those things. I think there's some wider work going on in the unit at the moment about how we're documenting those things as well. So we have been auditing it. Essentially, the audit comes up the same every time, which is as we get an influx of new nurses that are focused on kind of learning their hard skills around caring for ICU patients, things like the diaries, the orientation boards, the person-centered care stuff falls off because their learning needs are kind of centered around medication delivery, the different interventions and medical treatments that are used on ICU. So it's a big challenge. and one we're kind of constantly trying to work on, but there is no easy solution. We do hot topics on the unit in the morning, so there is essentially a list of things that we run through that everybody is prompted about that changes month on month, and a teaching topic for each month. So we're starting to integrate Delirium and orientation boards into that. And we've also been doing, one of the kind of rehab nurses has been doing some teaching, some tea trolley teaching for the nurses about Delirium as well, which is something we're keen to contribute to as well.
Thank you.
No problem.
Great.
Great.
So we'll send out, well, we thought it might be useful to put a bit of a kind of performer together if we're thinking about the feedback for next week. Is that something, just a show of hands, if that's something that it would be helpful to come to a reflection session with, just a bit of a template for kind of information, like a bit of a case study, I guess. If anyone thinks that would be useful, I can send that out. I can see some nodding heads, so I'm gonna I'll put them together and send it out. Yeah, and then yeah, I think Denise has sent out a questionnaire as well, just to try and mark yeah, just kind of see what the benefit of what we're doing. So that'd be great if you could fill that out as well. That'd be really helpful for us. Okay, if there's nothing else, then yeah, we'll let you go. Thank you so much for everyone for coming, and see you on the 16th.
Thank you.
Thank you.